विहान चार्जर दे दो मुझे। चार्जर दे दो। लाइव हो गई। Hello everyone. Good morning. Good afternoon rather. Let's start with the queries. Okay. So first query is of Dr. Rachna. Question number 41 and 46, right? Question number 41 is the commonest chromosomal anomaly in the early spontaneous isolated abortion. So let us discuss all the questions related to that. Okay, so for question here it is asked that what is the most common anomaly, right? So most common anomaly for first trimester spontaneous abortion. So the answer is chromosomal anomalies. Okay, chromosomal anomalies. Now, which anomalies are there? Which chromosomal anomalies are there? They are very good. Autosomal. There are two type of autosomal chromosome and sex chromosome. So autosomal trisomies. Okay, so now trisomies which are responsible, the trisomies which are responsible, they cause abortion of each and every chromosome. For we have chromosome 1 to 23. So they cause the trisomies which are causing abortion are present for all. Okay, are present for all. They are present for all. Question number, so 1 to 23, all trisomies are present. Okay, and next chromosomal anomaly is monosomy. And now monosomy is present only for one chromosome. Okay, monosomy is present only mostly for one chromosome, that is monosomy X, right? Now when they are specifically asking you which chromosomal anomaly it is, then you have to answer it is autosomal trisomy. It is autosomal trisomy. But now when they ask you with the chromosome number, when they are asking you with the chromosome number, when they are asking you, then you have to answer it is monosomy X. Okay, because every chromosome trisomy is present, right? Every chromosome trisomy is present, but monosomy is present only of X. And what is monosomy X called as? Can you please write down in the chat box, all those who are present, what is the monosomy X called as? Yes, very good, Dr. Nimra. It is most common specific. Specific here means with chromosome number. Okay, so then you will say Turner. If they ask you most common anomaly, then you are going to tell it is autosomal trisomy. Is it clear? Should we go ahead, Dr. Rachna? Is it clear to you? When they are asking specific, that is with chromosome number, then you have to say Turner. And when they are not giving you the number, then you will say autosomal trisomy. Let me see question number 46. 46 was contraindication of encirclage. Now, what is cervical incompetence? Let us discuss it. What is cervical incompetence? Cervical incompetence means that cervix is not able to hold the uterus. Cervix not able to hold fetus, right? And it gets loose and fetus comes out. It gets loose and fetus comes out. Okay, so its diagnosis is by TVS in pregnancy. If you want to diagnose this, yes, we are discussing, Dr. Rachna. If we are diagnosing it with, okay, and let me see what is that diagnosed TVS. And if the patient has come to you non-pregnant for preconceptional counseling, then you have to Hagar dilator test when non-pregnant. Okay, clear Hagar dilator. Which Hagar dilator passes? Can you tell me which Hagar dilator passes? Is taken for it? Number 8. Number 8 is taken. Okay. Yes. Now, next is its treatment. Its treatment is cervical encerclage. Encerclage is not done in the cases where there is positive, where there is labor pains are positive. Okay, when the labor pains are positive. Now, Dr. Rachna is asking why it is not fetal fibronectin test. Beta, fetal fibronectin test is positive. It is taken as positive from which to which time? Can anybody help me? Fetal fibronectin test diagnose preterm labor pain when present in which gestation? Can anybody tell me when present in which? Dr. Rachna, can you tell me? No, it is 24 to 34 weeks. Okay. Otherwise, presence of it is considered normal. Okay. Otherwise, presence of it is considered normal. Okay. Otherwise, fetal fibronectin, if present less than 24 and more than 34 weeks is normal. Have you got it, Dr. Rachna? Now answer to the question number 46 was, this was question number 46. Answer to the question number 46 was ruptured membrane. Ruptured membrane. If ruptured membrane is present, it means we cannot, if the ruptured membrane is present, it means we cannot conserve fetus. Okay? Is it okay? Okay. Next query is, Dr. Nimra has asked 19 number question. 19 number. Okay, let us do 19 number question. Dr. Nimra, question number 19 is treatment of choriocarcinoma. They have asked treatment of choriocarcinoma, right? Right? They have asked treatment of choriocarcinoma. Because first the patient had molar pregnancy and now the patient, first the patient had molar pregnancy and now the patient has again come with chest x-ray cannonball appearance. So the diagnosis is choriocarcinoma. So beta HCG is also high and everything. So diagnosis is choriocarcinoma. This molar pregnancy has become gestational trophoblastic neoplasia of choriocarcinoma. So what is its treatment? Its treatment is, of course, it is chemotherapy. Now either we have to give only the single agent. It has its two treatment, IMACO, that is multiple drug, or it is single drug, depending on what we calculate the risk score. Okay, it has two treatments. Choriocarcinoma treatment is chemotherapy. Now which drug to choose depends, it has two treatments, single drug or Imaco multiple drug. When we have to use single drug, then we use methotrexate. Now, how to choose which drug, single drug, we have to give single drug or multiple drug? It depends on the scoring. Okay, we do the scoring. If scoring is less than 7 or scoring is more than 7, if it is less than 7, then we have to give single agent or single drug methotrexate multiple doses with folinic acid. Okay, if the scoring is more than 7, so we have to use Imaco. So scoring is very complex. So I would like to tell you what all will be given to you will be scoring less than 7. Okay, so I would like to tell you that because scoring is very complex, so I would not advise you to learn the scoring at this time. You just remember, if they are not giving you scoring, then you have to choose whose single agent drug methotrexate. And if they are giving you scoring and then asking you, then you can go for Imaco. Okay. Okay. Let me take the next question. Is it clear, Dr. Nimra? If you want, then I can tell you the scoring. Okay, sorry. This was question number 20th. Yeah, it was wrong. Let us take first question number 19. Okay. Okay, question number 19 is that there was history of 2 second trimester abortion. So what is the diagnosis? Can anybody tell me what is the diagnosis in question number 19? Then we will discuss the investigation of choice. Please write down fast. Yeah, it is cervical incompetence. Very good. Now, cervical incompetence patient can come 2 times. Either it can come preconceptionally or it can come during pregnancy. What is the test which we do preconceptionally? Investigation of choice preconceptionally. Come on, everybody, please make it fast. This has been asked in the FMG previously. It is Hagar dilator. We pass Hagar dilator number 8. Okay. And if this Hagar dilator, very good, Dr. Sheffi. If this Hagar dilator number 8 passes, this is very thick dilator. If this passes, then it means that the cervix is incompetent. And what is the investigation of the choice for cervical incompetence during pregnancy? Come on, everybody. What is it? During pregnancy, what is it? And what we see on TVS? The investigation of the choice during pregnancy is transvaginal scan. And what we see on transvaginal scan, everybody? We see the cervix shape plus we see the cervix length. Okay, because in the question the patient has come preconceptionally. And Hagar dilator test was not there. So we go to the second option. Okay, what is the second most common cause? What is the second most common cause of recurrent pregnancy loss? What is the second most common cause of recurrent pregnancy loss? It is anatomic anomalies or Mullerian anomalies. And what is the test we do for Mullerian anomalies? Hysteroscopy. Is it clear? This question is clear to every one of you? Everyone, it is clear? Question number 19 is clear? No, beta, because in the Hagar, see, because in TVS, what we are seeing? We are seeing cervix length, okay, and number two, we are seeing the shape, cervix shape, okay. Is it T shape? Is it V shape? Y shape, V shape, or U shape? All these things can be seen only and only on the only and only when the Jai Shri Krishna, Dr. R.P. Soni, all these things can be seen only during pregnancy. Only during pregnancy. Cervix length will not get short unless and until the lady is pregnant. Only during pregnancy. So whenever they are asking you the test of cervical incompetence, you have to see whether they are asking you preconceptionally or during pregnancy. Is it clear? Is it clear? Dr. Nimra, is it clear? Okay. Question number 58. Question number 58 is, yes, this lady has recurrent abortion at 14 to 16 weeks. Okay, so it is a patient, this lady had 5 abortion. Okay, this lady had history of 5 recurrent pregnancy losses in second trimester. Okay, now they are asking you which test one should do. What is the most common causes? Cervical incompetence. Then it also can be fetal chromosomal anomalies. Some chromosomal anomalies, they also abort, right? And then there is Apla syndrome, it is asking you. Okay, see, there is recurrent pregnancy losses in second trimester, and this time one missed abortion in 12th week. So this is first trimester. Okay, so this can be the case of cervical incompetence or anatomical. So most common causes cervical incompetence or Mullerian, and the third is beta. Third cause is Apla syndrome. Okay, now because one abortion was there in the 12th week also. One abortion was there in the 12th week also. So we will also go for the chromosomal Yeah, Dr. Nimra, it is right. Yeah, it is right. Okay. So Apla syndrome, Apla syndrome. So for because one abortion was there in the first trimester, so we can also go for the chromosomal karyotyping to find the trisomy or the monosomy. Chromosomal karyotyping, right? Now the answer to this question is VDRL, that is syphilis. Syphilis beta never causes, please mark this slide, many times they are asking you twisted question. Syphilis never causes recurrent pregnancy loss in second trimester. Okay, syphilis never causes recurrent pregnancy loss in second trimester. Why? Because you all know which law syphilis follows. Kasowitz law. Syphilis follow Kasowitz law. What is Kasowitz law? That with each trimester, with each pregnancy, period of gestation increases. Now, how abortion occur in syphilis? How abortion occur in syphilis? If one abortion is occurring at the first trimester, then the next abortion will occur in the second trimester, and next will occur in the third trimester, and next time you will have a newborn baby. Okay, so syphilis is never going to cause recurrent abortion. Okay, syphilis is never causes recurrent pregnancy losses in second trimester. Is it clear? Is it clear, everyone? Dr. Nimra, is it clear? So we will not get the VDRL test done of the mother and father. Okay. So one more thing is there. One more question is asked on this. Which infection does not causes recurrent pregnancy loss? One more question is asked. Torch. Torch infection never causes never causes recurrent abortion, because once the torch infection occurs, then immunoglobulin G is formed, so it never causes recurrent abortion. So neither the syphilis causes is recurrent abortion, nor the torch causes recurrent abortions. Okay, they both causes abortion only one time. Okay, now let me see the next question. Dr. Rachna has asked question number 44. A female having 14 weeks IUD. Now, first of all, tell me, what is the second trimester abortion drug? Drug of choice. Please write down in the chat box. Be fast to write. If we want to do second trimester abortion, okay, to be very specific, Dr. Nimra, Dr. Rachna, the drug of choice are prostaglandin. Prostaglandins. It can be any prostaglandin. The drug of choice is prostaglandin once the patient is more than 12 weeks. Okay. Once the patient is more than 12 weeks, then the drug of choice is prostaglandin. Why we use prostaglandin? Because prostaglandin do cervical ripening. Because in the second trimester, the pregnancy is a large pregnancy, and we want first the cervix to get ripened, and then we will remove. Okay. So it is a mini labor type abortion. Okay, mini labor. Like first we ripen the cervix in labor and then we get the fetus delivered. In the similar way, in the second trimester, because pregnancy is now a large pregnancy as compared to the first trimester, we will ripen the cervix or soften the cervix with the prostaglandins, and if the expulsion occurs, then it is okay. Otherwise we remove the fetus by suction and evacuation. Okay, for RPOCs. Now in this question they have asked you, it is mini, it is not mini laparotomy beta, it is mini labor. Second trimester abortions are mini labor. Okay, second trimester abortions are mini labor. Okay, so now because there was IUD in the question number 44, it was IUD. Now what is the mechanism of action of mifepristone if it is given in first trimester? What is the mechanism of mifepristone and what is the mechanism of misoprost? Please write down fast. Please write down fast. Let us let us finish the session. Mifepristone, it kills the fetus. Very good, Dr. Nimra. It kills the fetus. And misoprost, it expels the fetus by inducing uterine contractions. Okay, by inducing uterine contractions. Very good, very good. So now in this question number 44, or Dr. Rachna, now is it clear to you? In 44 it was already IUD. In 44 it was IUD. So we will not give mifepristone because fetus is already killed. Okay, because fetus is, very good Dr. Shefi, fetus is already killed, so we will not give, we will give misoprost. Dr. Hassan has asked, what is the role of folinic acid? Beta, it is given with the now it is asked, what is the role of folinic acid? When we give methotrexate, then there occurs lot of problems to other cells. Okay, due to the methotrexate action on other cells. To minimize those action, we give folinic acid. Okay, to minimize the side effects, to minimize the adverse effect or side effects of methotrexate on other, or you can say normal cells, we give folinic acid. It is antidote beta. Dr. Shefi has asked second, fourth and eighth. Let us take those questions. Fourth and eighth. Now let us see question number 4th and 8th. They are very good questions. Just listen here. Yeah. Just listen here. Question number 4, what was there? That normal delivery occurred. Okay. Then at a gap of 3 months, the patient had bleeding. Okay. This was question number 4. The patient had bleeding. Okay. I may be wrong in numbers. There can be other numbers. Yeah, this was question number 8. 8, that after normal bleeding, normal delivery, the after 3 months bleeding occur. What is the diagnosis? What is the diagnosis, right? So here I would like to tell you key the diagnosis is of course a secondary PPH. And what is the cause of secondary PPH? Please write down in the comment section. Everybody, please write down. Questions are not repeated in exam. Topics are repeated. This is FMG PYQ. Please write down what is the cause of secondary PPH. Retained placenta. Very good, Dr. Nimra, Dr. Shefi. It is retained placenta. So the answer for question number 8 was retained placenta. Is it okay? Dr. Nimra, Dr. Shefi, is it okay? Now let us take question number 4. What is question number 4? Question number 4 said कि after the bleeding, this patient went to a doctor and the doctor did DNC. Okay. Now the doctor did DNC. Okay. It means that retained placenta, if would have been the cause, it would have been solved. But now also the patient is having bleeding. Now what is the cause? After doing DNC, again the patient is having wing bleeding. Now the cause cannot be retained placenta. Now the causes, can anybody write down in the chat box what is the cause now? Yes, now this time this is the trophoblast of the placenta has gone and it has caused GTN. Is both the question clear, Dr. Nimra and Dr. Shefi? Dr. Hassan is asking question number 24. Let us take that. Question number 28. Sorry, question number 24. Okay. Most useful investigation in suspected ectopic. What is the most useful investigation? Can anybody tell me? The confusion among you is transvaginal scan and beta HCG serial determination. Right? Can now anybody tell me why the answer was TVS and why the answer was not beta HCG? Okay, let me tell you. Because most commonly ectopic patient, no, most commonly ectopic patient presents with pain around 6 weeks, or you can say more than 4 weeks. By that time, very clearly we can see it on ultrasound. Okay, we do this beta HCG serial determination test if, yeah, is it right? You are right, Dr. Sheffi. You are right, Dr. Nimra. But you can say one more answer to this question is that most commonly ectopic patients presents with pain around 6 weeks. Okay, they most commonly presents with pain around 6 weeks. Okay, or you can say more than 4 weeks. So at that time, very clearly we can see it on ultrasound. Is it clear, Dr. Hassan? Is it clear, Dr. Hassan? Now, Dr. Nimra has asked serial determination of beta HCG. What was that question? Serial determination of beta HCG. I don't remember the number. Serial determination of beta HCG. Okay, let me see question number 12. Yeah, serial determination of beta HCG. Beta, in the ectopic pregnancy, now only we studied that transvaginal scan is the best investigation, right? But yes, if the patient come to us less than 4 weeks, then we do serial determination. But how many times we do in ectopic? Dr. Hassan? Yeah, Dr. Sheffi, we will take it after this question. Dr. Nimra, can you tell me? Dr. Nimra, how many times? Dr. Hassan, can you tell me? How many times? No, we do only 2 times. We do only 2 times. Okay? 2 times at a gap of 48. Very good. And how many times we do in molar pregnancy? How many times we do in molar pregnancy? Beta HCG determination, how many times we do in molar pregnancy? Dr. Nimra, Dr. Hassan, Dr. Sheffi? We do it for 6 months. Right? We do it for 6 months. Okay? Almost we do it every weekly for 2 months and then every month. So you can say that we do it 12 times. Approximately we do it 12 times. Is it okay? Now for the viability of pregnancy. For the viability of pregnancy. Again we do it 2 times. Okay, for the viability of pregnancy, we do it 2 times. So, and for the gender identification, we don't do it. For the gender identification, we not do it. So, if we have to choose one option, the best option is molar pregnancy. Because in molar pregnancy, we do it 12 times. Is it clear? Is it clear? We don't do serial determination for gender identification. Dr. Hassan, is it clear? If any other queries left, please write down in the chat box or we will close the session then. Dr. Shefi has asked abortion techniques in different trimester. Okay. What are the techniques in first trimester? What are the techniques we use in first trimester? Dr. Joseph has asked question number 13. Yeah, we will be taking it. Okay. Now, what are the techniques for first trimester MTP? What are the techniques? Can anybody tell me? Most commonly up till, yeah, up till 9 weeks. What is we use? We use MIFI and meso combination, right? Or you can say Dr. Ajit Joseph Paul has tell us, yeah, very good. Or up till 9 weeks, Dr. Paul has also tell us that it is medical method, right? If it is more than 9 weeks, what method we use? Can anybody tell me? If the pregnancy is from 9 weeks to 12 weeks, what method we use? If the question comes in exam, what you will, yeah, very good. It is suction evacuation. Dr. Paul has very clear it's suction and evacuation. Okay. Still, if some products are left, then we do DNC. Okay. DNC is the method which we do only if some products are left. Okay. And with which device we do suction and evacuation? What is the preferred device? Can anybody tell me? MVA syringe. Manual vacuum aspiration syringe. Okay. DNC we only do for, yes, retained products of conception. And what are the method we use for second trimester? As already discussed, Dr. Shefi, in the second trimester is mini labor. So the method of choice is, yes, prostaglandins and followed by suction and evacuation. What are the other methods? Recently in INSET they have asked you the other methods. What are the other methods which we use? This is the method of choice. Cervical ripening with prostaglandins followed by suction and evacuation. What are the other method which we can use? We can use extra amniotic ethacridine, okay, and intra-amniotic, very good, intra-amniotic, very good, Dr. Nimra, hypertonic saline or glucose, okay. So these are the methods which are reserved for second trimester. Let us take Dr. Paul question number 13. Dr. Shefi, is it clear to you? What is question number 13? Question number 13 is maternal serum alpha fetoprotein. Alpha fetoprotein Alpha fetoprotein is something you can say biochemical marker for anomalies. Is a biochemical marker for anomalies. Okay, now which all Taran mnemonic for it is AFP is increased in. हेलो, कितने बजे? ठीक है, ठीक है, ओके, ठीक है, ठीक है, ओके, हाँ जी, हाँ जी. AFP is increased in anomalies. T stand for twins. A stands for anterior abdominal wall defects. R stands for renal anomalies. And N stands for NTDs. Okay, neural tube defects. Is it okay? And AFP is maximum in anterior abdominal defects are of two types: gastrochesis and omphalocele. Okay, and omphalocele, because in gastrochesis there everything is out, because in gastrochesis everything is out and not covered by peritoneum. So there is maximum. Yeah, very good, Dr. Nimra. Very good, Dr. Nimra. So not covered by peritoneum. So maximum increase of alpha fetoprotein. Is it okay? Is it okay? Can you tell me? Is it okay, Dr. Joseph Paul? Can you tell me in which condition AFP is decreased? In which condition alpha fetoprotein is decreased? This is another question. Please write down in the chat box. Very good. Yes, alpha fetoprotein is decreased in Down syndrome. Okay, so just learn this mnemonic. Taran. Twins, anterior abdominal wall defects, renal anomalies, and neural tube defects. And you will answer it. And maximum it is in gastrochesis. Okay. Any other doubt? Please ask. Please feel to ask. Yes, every neural tube defects has increased alpha fetoprotein because membranes are exposed. Whenever the membranes will be exposed, there will be increased alpha fetoproteins. What is the diagnostic test we use most commonly for diagnosing neural tube defects? Can you write down in the chat box which test we use? Dr. Nimra, I am not understanding your question. Which test is best for diagnosing neural tube defects? This is, you do it wrong. Maximum time. Best test for diagnosing NTD or or anterior abdominal wall defects? Yes, very good, Dr. Sheffy. The test is ultrasound. No doubt, alpha fetoprotein is increased, but we don't wait for the alpha fetoprotein. We usually diagnose it by ultrasound. We usually diagnose it by ultrasound. Any other query? So today our obstetrics is complete, and tomorrow onwards we will be doing gynae revision. Okay. So happy new year once again to all of you. In the live I didn't wish you happy new year. So once again happy new year to all of you. Okay. Thank you everyone. So I think no queries are left. We should close the session. Thank you everyone. Don't say thank you again and again. All these things are mutual. Okay? I also need you. Okay, so here we close the session.